Morning, everybody. So I'd like to thank John Petty for asking me to give a TEC talk. He said, hey, we're going to do these TED Talks. They're going to be inspirational, ideas worth talking about, different format. I says, wow, that sounds great. He says, I want you to give your talk on C-spine injuries. Okay. I think we can be very inspirational about this. I think it seems pretty boring and pretty mundane, but this is actually an important issue for us. Let me ask for a show of hands. How many of you are going to go back to work on Thursday and just send a kid home from the ED with an undiagnosed or missed cervical spine injury? Who wants to do that? Dr. Barksdale does. All right. Jeff Upperman, Peds Trauma Man, Trauma Medical Director at Children's Hospital Los Angeles. Your trauma center wants to send all these kids home with injuries? He says yes. Don't put that on Twitter. That's probably not a good thing. None of us want to send these kids home with injuries, right? And I think that visceral response of missing a cervical spine injury leads us all to over-image these kids. Show of hands, who thinks they over-image C-spines in trauma? Most of the room, right? And we're talking to a group of pediatric surgeons. So we are the experts in pediatric trauma, and we self-admittedly over-image. So the goals of my talk really are to provide you with some tools and some guidelines for how we can decrease imaging for cervical spine injury in kids. Who can we get away with not imaging with good outcomes in the long term? Talk about some cases to start. So I've changed all the names on these, but Sarah, I'm sure all of you have seen a kid like this, high-speed motor vehicle crash. She was restrained, wearing her seatbelt, airbag went off. Comes to your trauma bay, and she actually looks pretty good. GCS is normal, she's talking, no loss of consciousness, hemodynamics are normal. Her right shoulder hurts, and she's got terrible neck pain. Show of hands, who will screen this kid with plain films? Okay. Who's going to go straight to advanced imaging? Okay, CT, MRI. When I say advanced imaging, CT, MRI. Okay, so and about half people didn't vote. Does that mean you're just going to clear them clinically with neck pain? Okay, so half the people aren't voting. Hopefully by the end of my talk, we'll get everybody engaged in voting, and I hope I don't fall off this stage because it's really small. All right, so she comes in and she gets wonderful, beautiful plain films. And this is pretty typical in kids. They've got nice thin necks, not a lot of chronic changes. These are beautiful. You don't quite see down to the top of T1 on the lateral, but you see a nice, beautiful set of C-spines. These are normal. The radiologist says they're normal. They're great views, except she's got this wicked clavicle fracture on the right side, which is leading to her pain. No focal neurodeficits. She just has pain. Who wants to clear her now clinically? Just take her collar off. Nobody? Okay, good. Who wants to go to advanced imaging now if you didn't do so before? So 3, 4, 5. Who wants to just send her home in a collar and re-examine her? It's really hard to see with these lights, but about 6 or 8 people, it looks like, and still nobody's voting. That's great. All right, so I'm actually a big fan of sending these kids home in a collar. Unfortunately, the collar sits right on top of that clavicle fracture, and that really hurts. So her compliance with that collar is probably going to be pretty minimal. She's 14, she can get an MRI without sedation, and the scanner was available, so we sent her over for an MRI. And it shows she does have a ligamentous injury. Her ligamentum flavum is torn at C7 on T1. This is not an unstable injury, does not need surgery, needs a collar for 6 weeks. So we could have sent her out in a collar and probably treated her without the MRI, but this gives you a little bit more information, a little bit more motivation for her to wear her collar that probably hurts over her right shoulder. But I think this is pretty typical of the MRIs that we get in these kids who have normal plain films, that they do have these ligamentous injuries, but none of them are unstable, and they almost never need a surgery. Let's talk about another kid, Devin. He's 12. He was in a car similar to that white one, restrained front seat passenger, and was hit by a car similar to that black one, a big SUV head-on. And Devin's in pretty rough shape. He's taken to a local receiving center, which is not a pediatric trauma center. He's hypotensive, his GCS is 8, and they intubate him. And as most non-pediatric trauma centers do, they do a pan scan, and it's quite an impressive scan. He's got lots of injuries, including a head injury. He's transferred to our pediatric trauma center for management of all of his injuries. And you can see some of his imaging here. He's got a little epidural, but he turns out to have a much more severe TBI, as he has some contusions that flower in the next 24 hours and doesn't really wake up all that much. But he got a real pan scan, top of his head down to the bottom of his feet at the adult center. And he's got some pretty bad femur fractures that on the first day, because of his head and instability, he just got X fixes and got his open fracture washed out. And then he has to go back to the OR the next day to get the left side nailed. And then he goes back the next day to get the right side fixed because we wanted to limit the amount of anesthesia time because of his head injury. So 3 OR trips in 3 days. Anybody seen a patient like this? Okay. So unfortunately, Devin is kind of a big kid, and he was a difficult intubation. We did extubate him in the ICU, and when they had to re-intubate him for a second operation, this isn't him, clearly, he doesn't have a C-collar on, but he's a little obese, he's immobilized, he's gotten a lot of fluid, and it was a difficult intubation. So they nasotracheally intubate him with a scope. And anesthesia does not want to take that out. They're going to leave the endotracheal tube in for 3 days because he's got all these planned reoperations. He already has a completely normal, high-quality, high-resolution CT scan. In that 12-hour period that he was extubated, he wasn't following commands, but he has a non-focal exam. He moves all extremities. He withdraws from pain. Who would send this kid for an MRI so they can get the collar off within the first 24 to 48 hours? Okay, about 6, 8, 10% of the audience, okay. Who will just leave him in the collar until he's awake and examinable and clear him when he's clearable, okay? Who wants to just take the collar off based on a normal CT scan? 1, 2, you've been reading the adult data. I like it. We're going to talk about that in a little bit. All right, cool. So I named this kid Aaron after me because this is something that I probably would do. So a little 5-year-old boy was sent to his room for timeout because he wasn't behaving. And Dad was going to go to the Warrior game. Had to throw something in there about the Warriors. And he was mad that he didn't get to go, so he climbed out his window. And he fell and hit the roof and then fell onto Dad's car and sort of bounced his way down all the way to the driveway. It was a first-floor fall, but he had lots of things on the way down to break his fall. I could totally see myself doing this when I was 5. He comes in, he looks like $1 million. No loss of consciousness, he cried immediately. He's complaining of terrible arm pain and a little bit of leg pain, but otherwise looks fine. Who wants to screen this kid with plain films? Okay, most of the audience. Advanced imaging right away. Who wants to get a CT of this kid's C-spine? Nobody, it looks like. Maybe one in the back? Okay. Well, unfortunately, he didn't go to a pediatric trauma center. He went somewhere else where they pan-scanned everything: head, neck, chest, abdomen, pelvis, which of course all was negative, and he could have been cleared clinically with clinical prediction models. And he did have a broken arm that ended up needing to be fixed. I think of all the things I'm talking about today, this is the one problem that we as pediatric surgeons need to address. We need to take ownership of this problem. We need to take ownership of the over-imaging, over-radiation of trauma patients at non-pediatric centers. I think we in our own centers do a great job of not imaging kids that don't need imaging, but we need to get the word out. So at the end, I'll share you with a tool that we can use to get the word out. Okay, so we have different mechanisms, different injuries, different ways to image, all these moving parts. So how can we make sense of these things? So the first thing I'll point you to, and I'm not going to go through all these guidelines, but these are really good guidelines. So these were written in 2013 by the AANS and CNS. Evidence-based guidelines. The best evidence in here is level 1, which says that if you want to diagnose atlanto-occipital dissociation, you should get a CT scan. I think that's pretty clear. Everything else is grade 2 and grade 3. The best thing about these is they tell us who doesn't need imaging. Who can we clinically clear without a single x-ray, okay? This is another thing that if you can just walk away with the first set of guidelines and know who you can get away with not imaging safely and share that with your adult centers, that would be huge. So kids you can communicate with, GCS 14 or 15, who are not intoxicated, you can clear clinically, unless they have a painful, distracting injury. 3 and under is an interesting population because they don't communicate all that well. But most of the time you can clear them. But the data suggests that if they have a high-risk mechanism of injury, particularly child abuse, where C-spine injury rates are very high, if they have one of these high-risk mechanisms, even if they seem totally fine, you should screen them radiographically, okay? Clinical clearance involves no neurologic deficits, so you actually have to do a neuroexam. No midline cervical tenderness, no painful distracting injury, and no unexplained hypotension. And then they have to be able to move their head in all directions without distraction, without any limitation. Clinical clearance works in a defined population of kids. And I think if we stick to this guideline, we can really cut down on the amount of imaging. The problem with this is the guidelines don't really tell us what to do when the neck hurts. What do you do with that kid who you can't clear them? The evidence for this is, quite frankly, terrible. I can't tell you what to do with these kids, but there are many options, and the evidence is emerging as to what we can do with these kids to, again, decrease the risk of radiation. So we talked about this kid earlier, normal plain films, but still has neck pain. So do all these kids really need to go get an MRI in the ED, or do they need to be admitted overnight so they can get an MRI with sedation the next day? You're going to give a kid general anesthesia to get an MRI. Or can they be sent home with cervical collar from the ED with follow-up in 1 to 2 weeks with a reattempt to clear them clinically? I think the biggest concern here is, are we sending potentially unstable injuries out of the ED? And what if that kid takes their collar off and there's a lapse and they have a neurologic deficit because we sent them home in a collar and we don't know that compliance is going to be 100%? So there's a great paper out of Boston, a few years old now. They looked at 300 kids who had no fractures on their imaging in the ED. And they followed them up. They actually had 94% follow-up. That's pretty good. The bottom 2 points are the most important. Only 2% of these kids had a ligamentous injury on their MRI, and none of them required surgery. None of them were unstable. So it actually is safe to send kids out from the ED in a collar. 84% of the kids that were sent out in a collar had it clinically cleared at their first clinic visit 1 to 2 weeks later. 84%. That's a lot of MRIs we can cut down on. That's a lot of CT scans we can cut down on. 10% required persistent use of the collar beyond the first visit, referral to neurosurgery, subspecialty follow-up, and MRI. But again, very few of those patients who had normal initial imaging had an injury that required surgery. They only lost 18 kids to follow-up. I think this is what we all worry about. You send a kid out in a collar, are they going to come back? And this is going to vary by center. I would hope that those kids would have come back if they developed neck pain or symptoms, but that is always the biggest concern of sending kids home in a collar. What about the kid who's obtunded in the ICU? Do we just clear him? Do we get an MRI? Do we wait? What do we do? Well, the thing we worry about are pressure ulcers. Anybody seen a pressure ulcer from a collar? Yeah, I saw 3 of them last year, and they can be pretty terrible. We all know who the patients are that get these. They occur 6 to 38%. They occur on the clavicles, back of the head, base of the neck, and these can be pretty bad. They occur in kids in the ICU. They occur in kids who get a lot of fluid. They occur in kids who have ICP monitors, who are on the ventilator. We know who these kids are. One of the biggest independent risk factors is whether or not you had to get an MRI to clear their C-spine. If they had to wait for their MRI, they were more likely to get an ulcer. But the real question is do they really need an MRI? And I think this is probably the biggest controversy right now, is whether or not these kids need an MRI. This is the adult data that I think some people have alluded to. This is a meta-analysis of 5 studies that looked at 1,000 patients that have normal, completely stone-cold normal CTs of their C-spine. No osteophytes, no degenerative disease, stone-cold normal CTs. Again, these are adult patients. They found on follow-up that 9% who ended up eventually getting an MRI had stable injuries that required no treatment. 91% had no injuries on either MRI or clinical follow-up. The most important part is that no single patient in these 1,000 that had a stone-cold normal CT scan required surgery to fix an injury. So these were all stable injuries. So the recommendation in adults now is to take the collar off with a normal CT scan and don't send these patients to MRI. I don't think this is applicable to kids. We know that kids have greater frequency of ligamentous injury, unstable ligamentous injury, but we are now going to start getting pressure to clear collars based on CTs. I think we as a community need to come together and reproduce this study in kids. We could come up with 1,000 patients easily amongst our centers. Let's try to define that subset of kids that this actually applies to. I actually think this would apply to kids who are in the sort of preteen to teenage years, but the 5-year-old probably not. I think this needs more definition. But I do think we need to figure out how to get these collars off quicker, and sending a polytrauma patient to the MR scanner is not without risk. Finally, what about the kid like me who fell out of the roof and got pan scanned? What do we do about this problem? I think this is a rampant problem. We get lots of transfers from non-pediatric trauma centers that have been pan scanned without a real indication for that other than mechanism. I would like everybody to know about this new resource from the American College of Surgeons TEC program. This is a free download. You can all download it today. This was written by adult trauma surgeons, and it includes standardized evidence-based guidelines for imaging in trauma patients. We had a seat at the table. So there were 5 of us. Dr. Gaines, Dr. Bird, Dr. Malik, Dr. Falcone, and myself spent hours upon hours on conference calls discussing these things, and we made sure that there are pediatric-specific sections for CT of the head, C-spine, whole body CT, chest imaging, so forth and so on. There are evidence-based guidelines in here that you can share with adult trauma centers, with non-trauma centers, so that they can follow these for their imaging of pediatric trauma patients. I would ask that you download this, familiarize yourself with this, and use this in your outreach efforts to your referral centers that are sending you these patients. In summary, we have a huge opportunity to decrease radiation, sedation, resource utilization in these patients. I think that there are reasonable guidelines that exist, but we really need to improve these, and the only way to improve these is for us to be at the table, generating data, strengthening these guidelines, and really reaching out to the adult centers so that we can provide our expertise for them. Thank you for your time, and